Hello, everybody. Hope that you're doing well. I've been asked to go over arterial blood gas interpretation, so we're going to do a quick down and dirty of the ABG interpretation, or kind of how I try to simplify or explain it to individuals. But there is some terminology to start off with initially, so you need to understand the relationship uh, with pH and kind of looking specifically at blood pH. 7.35 to 7.45 is what we would consider to be within our normal range. And then anything that move, and if you look at neutral or being right in the middle at 7.40, really anything above that is moving more towards an alkalosis, and then anything moving less than 7.40 would be moving more towards an acidosis. However, we do give the tolerance of about plus or minus 5 on that scale, 7.35 to 7.45, uh, to uh, help us dictate what's normal and what's not. We also look, so the pH, if the pH is higher than 7.45, we're going to call it an alkalosis. The alkalosis is either going to be caused by the respiratory system or it's going to be caused by the metabolic system. There are some instances in which it could be a mixture of both, and we may brush on that shortly, but right now we just want to make sure that we can determine if the blood gas is normal, if it's abnormal, what the abnormal component of the blood gas is, and then try to look at if there's any type of compensation, if it's a partially compensated blood gas, if it's fully compensated, or what have you. So again, terminology that we need to make sure that we're appreciative is CO2, and understand that you have a respiratory component to your blood gas and a metabolic component to the blood gas. So if you're looking at a blood gas, you're typically going to have a pH, and you'll have to excuse my handwriting's not fantastic, but nonetheless, we'll deal with it. You have a pH, a PaCO2, a PaO2. You'll have a bicarb, um, an SaO2, and a base excess. So for all intents and purposes, when we're looking at our at the blood gas in of itself, we do want 7.35 to 7.45. You've got to make sure that you know those normal values, or else it's going to be difficult to determine what your interpretation of arterial blood gas is. PaCO2 is going to be 35 to 45, and that's millimeters of mercury. PaO2, 80 to 100. Anything less than that is going to give you some degree of hypoxemia. It's going to be mild, moderate, and severe. So mild is going to be anywhere between 60 and 79. Moderate is anywhere between 40 and 59. And then anything less than 40 is going to be considered severe hypoxemia. That also is going to be millimeters of mercury. Bicarb, your normal for your bicarb, your HCO3 is going to be 22 to 26 milliequivalents per liter. You may also see millimoles used there. SaO2, really anywhere above 92%. Whoops, writing my numbers backwards. 92%. And a base excess typically going to be within plus or minus 2. If it's plus, it's an excess. If it's a negative number, it's going to be a deficit. So really, when we go up here, if we're moving this direction, we're moving towards an alkalosis. If we're moving to the left or less than 7.35, we're moving towards an acidosis. And for the purpose of what we're doing as far as interpretation stuff is concerned, we will either be a respiratory acidosis or respiratory alkalosis, and metabolic acidosis or metabolic alkalosis. There are some situations where it can be mixed, but we're going to focus just on the differences between the two of those right now. So you have a respiratory component to your blood gas, and you have a metabolic component or a renal component to your blood gas. So those can be utilized interchangeably. So if we're looking at the respiratory component, the PaCO2 is going to be utilized as our respiratory component. And the bicarb is utilized as your renal or metabolic component. metabolic component, renal or metabolic component to the blood gas. And it's important to understand that if my blood gas results in a respiratory problem and I'm going to allow the body to fix it, the compensatory mechanism is going to be with the renal system. If I have a renal problem or a metabolic problem and I let the body try to fix it, the compensatory mechanism is going to be by way of the respiratory system. So the renal system will try to fix respiratory problems try to be fixed by renal issues, and so forth. So and we'll do some examples here shortly as we go through those. So we need to understand relationships with. We've already established that pH is going to determine whether it's normal, if it's acidotic, or if it's alkalotic. If you're above 7.45, you're alkalotic. If you're less than 7.35, you're acidotic. So we need to understand the ventilation component or the respiratory component. We're going to look at the PaCO2 for the respiratory component, and we're going to look at the overall effectiveness of ventilation. If your ventilation is ineffective, I mean, it's not effective, your CO2 is going to be high. So ineffective ventilation or hypoventilation is going to result in hypercarbia or hypercapnia, meaning your PaCO2 is in excess of normal where it's supposed to be. If your ventilation is effective, then your CO2 will fall within that range of 35 to 45 millimeters of mercury. And then if your ventilation is overly effective, then or you're hyperventilating, then your CO2, you'll be hypocarbic or hypocapnic. Your CO2 levels are going to be less than normal. So they'll be less than 35 millimeters of mercury in that point. So with understanding that your CO2 can go up, your CO2 can go down, it's important to understand the relationships that CO2 has with pH. So if I come down here and I have an increase in PaCO2, CO2 has an inverse relationship with pH. So as CO2 goes up, it will drive the pH down. And then on the flip side of that, if PaCO2 goes down, it will take pH up. So if you were to see this first scenario with an increase in PaCO2 and a decrease in pH, this is going to yield or equal a respiratory acidosis. If you have a decrease in your PaCO2 while the pH goes up, this is going to be a respiratory alkalosis. So that's your respiratory component, and we're understanding how it manipulates the pH. We also have a metabolic or a renal component, and that's going to be with our bicarb, and that has a direct relationship with your pH. So if I have an increase in bicarb, that is also going to cause or bring up my pH with it. That's going to yield or give us a metabolic alkalosis. And if I have a decrease in bicarb, that's going to give me a decrease in pH, and that's going to give me a metabolic acidosis. Now, remember, I said that if you had a respiratory issue, the renal system will try to fix it. If you have a renal issue, the respiratory system will try to fix it. So that being said, let me change colors here right quickly. If you were to have a respiratory acidosis, the compensatory mechanism for that, or how the body's going to try to fix that, is by way of a metabolic alkalosis. So those two will go together as far as the acid-base buffer system is concerned. Change colors again. If you were to have a respiratory alkalosis and we're allowing the body to try to fix that, the body would try to fix that by metabolic acid. So respiratory alkalosis, the body would, and you got to keep in mind this is over time. There's going to be some compensatory mechanisms that whether you increase your rate of ventilation, your depth of ventilation, if you decrease your rate and depth of ventilation, that certainly can change things a lot quicker than it takes for the renal system to compensate. But this is just, for all intents and purposes, if we're allowing each system of the body to fix the other, these are going to be what the sequences that take place. It is also important to understand that the respiratory system, you can alter your acid base a lot faster with the respiratory system than you can with the renal system. Case in point, I can sit here and hold my breath for a little bit, and if I'm undergoing arterial blood gas analysis, hold my breath or breathe really fast, however we want to do it, that is going to change the CO2 in my blood for a moment and so in time, and then that will reflect a different pH on that blood gas. But I cannot sit here and tell my kidneys, I need you to crank out more bicarb. I need you to crank out less bicarb. Can't do that. But I have direct control over the respiratory system, and I can certainly do that. So those are relationships that you've absolutely got to understand before you begin to start to look at, do I have a respiratory alcohol? Is it compensated, uncompensated, or what have you? So you also have to go back and remember the normal values. So first thing I would recommend you do, assess your pH. Is your pH normal? Is it acidotic? Is it alkalotic? And then what we're going to do is, after we've determined that, then we're going to begin to look through the different components of the respiratory component and the renal component of the arterial blood gas, and we're going to try to determine who's at fault for causing the pH to be whatever direction it is, whether that's acidotic or alkalotic. But these are going to be some normals that we absolutely have to make sure that we remember and understand. So I will also clear this, and we'll just type in a few items right quickly. So I'm just going to type in a series of blood gases, and keep in mind, for the purposes of what we're doing, everything's going to be PaCO2. PaCO2, start out with pH. PaO2, and for what we're doing right now, we'll just stick with bicarb, HCO3. CO3. And those should have a line over it, and you should have the 2s and 3s should be subscript. But we'll cross that when we get there. So that's the order in which I'm going to put all the numbers in. So if we look at 7.40, 40, and 24, this is going to be our pH, our CO2. I missed the PaO2. We'll throw 90 in there. So if we're looking at this set of numbers right here, that's essentially a pretty normal looking blood gas. 740 falls right in the middle where the pH is. Our CO2 is right in the middle where that's supposed to be. PaO2 is right in the middle where that's supposed to be, and our bicarb is right in the middle where that's supposed to be. So now let's jack it up. Let's throw some different numbers in here. Now, for those of you that are really astute into your arterial blood gas interpretation, I am just pulling random numbers. These things could be checked with the HH equation. You can call BS or what have you, and I understand that. But just for the purposes of showing these relationships, this is how I'm going to go about doing it. So if I were to come up here with a 7.28 CO2 of 55, PaO2, before we start throwing in levels or degrees of hypoxemia and so forth, I'll just leave it there. And the bicarb, I'm going to leave right there in the middle at 24. So if we happen to look at this blood gas right here, first thing I'm going to do is look at the pH, 7.28. That's acidotic. It's to the left of that graph that we had drawn a little bit ago. So at 7.2, that's an acidotic issue. Now I've got to determine with the rest of the blood gas, what is it that's causing it to be acidotic? So if I look at the ventilation component or the respiratory component, CO2, well, I understand I've got an inverse relationship with CO2 and pH. So if my CO2 goes up, pH is going to go down. So based upon what I know with that, it is possible right now that I'm looking at a respiratory acidosis, but I want to look at everything else because I'm going to assess the entire situation first. PaO2 is okay, not really going to have that significant of an impact or bearing on what the actual pH is going to be. Again, we're looking at your respiratory component and your renal component and the metabolic situation. So looking at the bicarb, my bicarb is 24 milliequivalents per liter, or right in the middle. It hasn't moved yet or not. So when I look at this, and I know that I have a direct relationship with my bicarb and pH. So as bicarb goes up, it should take pH up with it. As bicarb goes down, it should take pH down with it. So when I see an acidotic pH, the only thing in this blood gas that screams that it's driving it down is the high CO2 or the elevation in CO2. So I have a respiratory acidosis. And specifically, I have an uncompensated respiratory acidosis. Now, how did you come up with that? Well, the blood gas is compensated if that pH falls within normal range. So it can be a fully compensated blood gas with whatever the disturbance is, if your pH falls within that normal range of 7.35 to 7.45. If it's not normal, it's not compensated, and we can look at the other system to see if it's moving in the direction to help us compensate for that disturbance. So for instance, I'm telling you that it's an uncompensated blood gas here because my bicarb is right smack dab in the middle of normal. It's not moving in the direction to help fix this. So if we look at this blood gas, if I was going to depend upon renal compensation to fix it, then the body would need to begin to crank out more bicarb, because as the body's excreting more bicarb, that should hopefully help bring up the pH. Now, we know, because we're respiratory therapists, that if this patient were intubated, mechanically ventilated, all we have to do is make sure that whatever changes we're making with the ventilator increases their minute ventilation. Specifically, it would be great if we knew that we were increasing their alveolar ventilation, because alveolar ventilation is the only effective ventilation that you have. But nonetheless, that's what we're looking at doing. So if I take that same blood gas essentially and just go right beside of it, and now let's say that we're going 7.32, we'll leave the CO2 for grins and giggles at 55. We'll leave the PaO2 for grins and giggles at 80. And now I'm going to take that bicarb up to 27. So now this goes from an uncompensated respiratory acidosis to a partially compensated respiratory acidosis. How now do I know that it's partially compensated? Well, from this blood gas to this blood gas, the pH has moved back closer to normal. It's not normal yet, so I can't say that it's fully compensated. My CO2, I'm still hypercarbic, but now my bicarb, the renal component, I've got a respiratory problem. The renal component is going to work collectively together with that to try to help fix or bring it up. Because if CO2 drives it down, more bicarb is going to bring it up. Hence, again, the acid-base buffer system, your acid-base balance that we're trying to achieve. So this is partially compensated respiratory. It's still a respiratory acidosis because I have an acidotic pH. The problematic cause of that is the respiratory system, that high CO2, the inverse relationship driving the pH down. And I know that now it's creeped up a little bit. So if I draw in another blood gas, and now let's say we go 7.36, leave that CO2 at 55, leave this at 80, and now let's just say this is calling up to 29. Now, again, if you know your relationships with CO2's got to increase this much to cause an increase of one or an increase of one, however, with your bicarb, then, but again, these are just arbitrary numbers I'm putting out here for the sake of showing relationships with how arterial blood gases work. So now if I were to look at this blood gas, well, I'm on the acidotic side of normal. So I'm still hypercarbic or hypercapnic. I still have a high CO2. PaO2 is still okay, but my bicarb is 3 above normal. If normal is 22 to 26, so I've had renal compensation. My pH is back to within normal, so I have a fully compensated respiratory acidosis at this point. It's fully compensated respiratory acidosis because the renal system has now put out enough bicarb to buffer the excess CO2, and now we have a fully compensated respiratory acidosis. And the same can be true if we were to go with, uh, a respiratory alkalosis, metabolic acidosis, what have you. So let's kind of change up the numbers just a little bit and go through those here. So we did a respiratory issue the last time. Let's do a metabolic component this time. So um, let's just go with the metabolic alkalosis. So I'll go 7.48. We're going to leave the CO2 pretty much normal right now. We'll leave the PaO2 at 80, and I'm going to take my bicarb. We'll go to 28 here. So if you look at this, first thing we do, assess the pH. pH is alkalotic. Now I have to look and figure out why is it alkalotic? I'm going to look at the respiratory component. I'll look at the renal component. And I understand those relationships. If CO2 goes up, pH goes down. If CO2 goes down, pH goes up because they're inversely related. Bicarb, if bicarb goes up, it takes pH up with it. If bicarb goes down, it takes pH down with it, so forth. So they're directly related. So if I look at my respiratory component, CO2 of 40, that's not really jiving with running the pH up to an alkalotic side. So I'm not really ready to call it a respiratory anything. PaO2, again, not going to have much bearing on your overall pH per se. And then if I look at the bicarb, well, I know that my normal for the bicarb is 22 to 26 milliequivalents per liter, and I am above that. So that would take the pH up, and that is a respiratory alkalosis, a metabolic alkalosis. It's a metabolic alkalosis. So now we have to think, I've got a metabolic problem. The compensatory mechanism at this point would be for the respiratory system to try to help fix it, if you will. So we tend to look at something like this, looking at the next bit of series. So if I were to bring this to 7.46, oops, leave this at 40 and take that at, I can't leave that at 40. So now what I've got to try to do is we're trying to bring the pH down more toward a normal level. So if we're fixing that with the respiratory system, you would have to basically begin to hypoventilate a little bit so that you can become somewhat hypercarbic or hypercapnic. So we need to maybe say that the CO2 at this point is 47. We'll still leave this at 80, and we'll leave this at 28. So now if I'm looking at this, but first thing I'll do is look at the pH. Still on the alkalotic side, it's still an alkalosis. It's still a metabolic alkalosis. But this one, we go from an uncompensated metabolic alkalosis to now a partially compensated metabolic alkalosis. It's not compensated because the pH isn't normal, but it's partially compensated because now the CO2 has moved in the direction to try to help fix this blood gas and bring it down. So if you were to look at 7.44, and now we'll go to say 49, 80, and leave that at 28. Now we're looking at a fully compensated metabolic alkalosis. Fully compensated metabolic alkalosis. The CO2 has gone enough in the direction to help fix that. So we'll do one more series, and then I'll kind of talk about a couple other things, and then we'll be done for the day today. So if you were to look at let's go a little bit lower than that, 7.15. And CO2 right off the bat is 40, PaO2, leave it at 80. And let's just say that you had a bicarb of about 18 at this point. Might even be a little bit lower than that, but we'll go with 18 for right now. So based upon what we've talked about already, the relationships, you can look at that and know that the metabolic system is why that pH is acidotic. So it's metabolic alkalosis, a metabolic acidosis. It's an uncompensated metabolic acidosis. So if we were to look at some compensatory aspects of this, you have 7.20. Let's see here. Might go with 34 now, 80, and we're going to leave that at 18. So the pH has now come up just a little bit, but it's still not normal. But there's partial compensation. Things are moving back close to normal, and we're doing that now because in order to fix the metabolic issue that we have going on. The respiratory system is going to try to fix that. So now this patient's hyperventilating to try to help blow off the CO2 to bring that pH up just a little bit. And now, if we were going to have a fully compensated blood gas, we might look something like this: 3.5. We'll go with 24. Again, probably not likely realistic numbers, but nonetheless, they just for the sake of what we have here, for the sake of demonstration, a fully compensated metabolic acidosis. Possible that for a short period of time, you might, like, we would need to address whatever the issue is, because the patient, in order to achieve this type of compensated blood gas or achieve this type of compensation, their rate and depth of ventilation is going to have to be ridiculous. So they're going to be breathing extremely heavy and so forth. Kind of reminds me of if you've ever watched like the first Ghostbusters, when she's lying in the bed, that's not something an individual is going to be able to sustain for a prolonged period of time. They're going to tire out. And if they were to tire out and stop breathing, their CO2 is going to climb. Well, that CO2 now is going to cause the pH to go back down. And then that would be a situation where you have a mixed acidosis between respiratory and metabolic acidosis. They're also, so this would kind of be a typical type of patient that you could see maybe could come in and present with somebody that had that really deep ventilate. You would have call it the Kussmaul's ventilation or the Kussmaul's respiration. With that, those are going to be your DKA patients, your diabetic ketoacidosis patients. So I know that's been a little long-winded on trying to do a quick intro for our ABG interpretation, but it's really cool once you get it down, once you get those relationships down. And you never know, you might start thinking about singing about it a little bit. So, you might be like, so when I'm in my patient's room and they're going down, I take a step back, think, and I look around, I check out the heart rate, the blood pressure, the SpO2, because the therapist knows how we do. To check the adequacy of ventilation, I take a needle and syringe and do blood gas analyzation. I check the PaCO2 before I get some lube and insert a tube, be real mean and aggressive with the wean, so I hurry up and get you off that breathing machine.